Hey guys, give us just a second here to get Jess also on this with me. Which angle is better here? Maybe like that. There we go. And I can see my notes and I can see you guys. Okay. Just making sure that I sent the invite correctly to add Jess. Let's see. Go. Okay, there. I think she's joining now. Hey Jess, I accepted it like 2 times, so it should work, I think. Can you guys all hear me? Thank you. All right, today we're going to talk about preeclampsia, and while we get Jess added, I'll just kind of she's gonna go over some updates with Pacific Birth Institute, let you know what we've got going on and what's coming up, and then we'll do a deep dive into preeclampsia. We're going to go over what it is, how it can affect the pregnant person as well as the fetus, assessments you do, lab work you do, things like that to diagnose preeclampsia, talk about like why we care about it, what are the problems that can come from it, and then treatment management of preeclampsia. And then at the end, I just want to touch on postpartum preeclampsia because it's slightly different, but mostly the same. But I just want to make sure that it's something you think about when you are a pregnant person or you are working with pregnant people. I will preface all of this with what I wrote was initially designed to be an education for patients. So if I am nervous and just overread my notes, it might not sound like I meant to be talking to birth workers, but it's all very similar. So I apologize in advance if I'm not perfect at this. Oh. I don't know why it's not. Okay, let's see if I can maybe add Jess through her other profile. Yay, that worked. I don't know why the other one wouldn't work, but there you are. All right. So now we will officially start. You guys, my name is Jennifer Hoadley. I'm a certified nurse midwife, nurse practitioner in Alaska. My practice is based mostly in and around the Anchorage area. I do home birth and birth center birth. And Jess and I have been doing the Pacific Birth Institute thing now for 4 years. Is that right? Exciting.
Yeah, can you hear me okay?
Yep, I can hear fine. The goal of Pacific Birth Institute is to get more people involved in community birth work through education and advocacy. So we are working hard on the education piece of that, training people how to be birth assistants, because being a midwife takes a whole lot of time, but getting your butt into the birth room doesn't take that much work, really, if you can develop the skills to be helpful to a midwife. Being a birth assistant is an excellent career opportunity. It's also a great way to have a head start on an apprenticeship. So that's who we are, what we do, and I will let Jess introduce herself and start us off, and then I will come back for the lecture-y part.
Okay, and I'm gonna post part of a thing that I'll finish up on once we get into Jen's part again, but I did just drop a comment that is kind of our housekeeping, and it's, so go to our website right now. So first, hi, I'm Jessica Johnston. I'm a certified professional midwife. I am a NARM preceptor, so I love signing off on skills. I am currently enjoying a vacation in the warmth. So Jen may be up in Alaska, but I am not. So I am in South Carolina. I just helped sign off on the skills of the 4th CPM to be licensed for the state of South Carolina, and I was very happy to be a part of her licensing journey. That was really fun to drop into a new state and be able to do that. So we love working with students everywhere. In some housekeeping. So today we're going to go into a pre-eclampsia deep dive. It's going to be awesome. We're going to kind of talk fast, but we do want you to know we are going to have this uploaded. It's going to save. It's going to save. We're going to have it uploaded to YouTube, okay, in its fullness. So if you miss any of it, don't worry. You will be able to find it, and we will make sure it gets up there once we have it saved here. So if you have to go, don't worry about it. This will be about an hour time. We're going to go over a little housekeeping, Jen's beautiful deep dive into pre-eclampsia and all the stuff we want to know about it. We're going to do some questions and answers. And then other than that, Jen, we'll kind of just see what you guys want to talk about. We're going to be doing these. This is really the first comeback for us on lives weekly since probably the end of 2022. Yeah. And so it's been about a year. Yeah, we took a break. And so welcome to Birth Working. That's what we're calling it, because Pacific Birth Institute, our catchphrase is we are birth working. And so you're going to see a lot of guest interviews, guest expert interviews. We're going to have on different birth stories and midwifery stories. So journeys of different styles of birth workers. We're going to expand to really bring in an audience from the community. So not just midwives, not just doulas, a lot more students, and then actually some paramedic, EMS, MFM, hospital people who receive our care, our clients from when they have to transfer in. We're going to do topic deep dives like Jen's going to do today with pre-eclampsia, where we're going to take an hour, well, about a half hour, and we're going to dump a ton of info, chat, answer your questions, and then we'll have lots of other cool stuff coming up. So big thing, first, please get on our email list. We are emailing out a lot of things. We have on our website currently, if you haven't checked it out, we revamped some things. We have an interest form for Hawaii. We are looking at hosting a CEU and retreat combo thing between 3 to 7 days in the islands. I have been speaking with some people already in the islands, some birth workers, and so the interest form is up on our website. Please complete it. Right now it's looking like most responses want a January to March 2025 set date, and so the quicker we get responses, the quicker we can get a place booked. And we are all going to the islands. We're going to be doing CEUs. Right now, the biggest interest people have are in breech, suture, and community VBAC standards. So we're going to be looking at getting our CEUs qualified for those, for that retreat primarily. And then the biggest response we've had is people want access to massage and food made for them. So we're going to be getting some food made for us. And I need a massage
and some food.
Yes, we do, yeah. So if you're interested in joining us, please do fill out the interest form. It gives us more to work with. And I will drop some more stuff in the comments. But a big thing I want everyone to know who is watching, whether you are a student of ours or not, whether you're interested in becoming a birth assistant currently, please do go check out on our website. We have a birth assistant scholarship application. I'm going to encourage everyone to apply for our scholarship. And the reason why is We are going to be launching something brand new in 2024 that will be going directly to scholarship applicants primarily before it ever goes out to the general public, because it's going to be answering some of their needs distinctly. And so please, even if you don't want to be a birth assistant, but you want to find out what we're going to be doing, get on that scholarship application. It is going to be different than our newsletter. So, all right. I'm so happy to be here. I'd like to introduce my partner in crime, my favorite nurse midwife. Yes, Jennifer Hoadley. She's a nurse midwife, as she said, in the state of Alaska. Jen Hoadley doesn't actually talk herself up enough. She covers probably one of the largest ranges of services of care in the United States currently as a licensed provider who serves exclusively the community. And so she serves in the Alaska setting from the Kenai Peninsula through the Anchorage area, all the way up through the Mat-Su Valley. And so she has 3 locations of service because her skills are so desperately needed for rural access to birth. She takes TRICARE, so she really makes accessible VBAC experience and alternative birth modality to the military population, which is so needed because the transience of the populations and the fact that a lot of rural areas are losing hospitals. So today Jen's going to tell us all about pre-eclampsia. I'm so excited to have her with me always, but to be the one talking today. All right, Jen, take it away.
Okay, so preeclampsia is a typically blood pressure related complication in pregnancy that happens after 20 weeks of pregnancy. High blood pressure before 20 weeks of pregnancy is not preeclampsia, that's just high blood pressure. And then in addition to high blood pressure, there has to also be signs of organ damage, and it can affect the mom and the baby, and its exact causes are still not super well understood. Symptoms of preeclampsia can include swelling, sudden weight gain, headaches, and vision changes. So it's important for doctors and midwives to be monitoring our patients regularly. That's why we see pregnant people very, very frequently through their pregnancy is, monitoring for preeclampsia and other complications is the point of prenatal care in addition to education. The pathophysiology of preeclampsia is incredibly complex. It has to do with how the placenta attaches to the maternal uterus, and in a healthy pregnancy, when that attachment happens, it causes the maternal blood vessels to soften and relax, not only at the insertion site, but throughout her entire body. However, in a preeclamptic type insertion, those blood vessels, instead of getting soft and loose, actually get more firm at the placental site and throughout her entire body. And that rigidity of the blood vessels limits the ability of the exchange of oxygen, carbon dioxide, as well as nutrients at the insertion, throughout her entire body, so at the capillary beds. So this restricted blood flow can cause brain damage, kidney damage, liver damage, and in the baby, it can cause growth restriction, decreased fluid, and then, of course, lack of oxygen over time can cause fetal distress and even fetal death.
Jen, can I ask you a question? Can I ask you a question? So if I'm hearing you correctly, and this is, me opening that topic up, is that pathophysiology, that rigidity, not only affects the amount of blood that's going to the baby, it is actually working its way back through the maternal system, the physiology.
Entire maternal capillary bed gets rigid and stiff. And I'll get a little bit more into it further down here, but it's like there's a specific hormone that is just not produced correctly, and which causes that rigidity of the vessels, and it can cause permanent damage to the kidneys and liver if it's not treated, if it's not caught and taken care of quickly. So current theories about the cause of preeclampsia is a combination of genetic and environmental and immune system responses, so they all kind of work together, so it's not just one or the other. So people who are most at risk for preeclampsia is first-time pregnancies, Age is an interesting risk factor because it's teenage moms and then those moms over 35. The people that we typically view as like the healthy range for pregnancy are at the lowest risk of developing preeclampsia. Family history. If you have a mom or sister who had preeclampsia, you are much more likely. Again, that's that genetic component. And then there's medical conditions that can increase your likelihood to develop preeclampsia, things like chronic high blood pressure, diabetes, kidney disease, and autoimmune disorders. And then multi-gestational pregnancies is a risk factor, so twins, triplets, or more. Being overweight is an increased risk factor. Having had preeclampsia yourself in the past puts you at risk. Again, remember, it's genetic and environmental thing, so that makes a lot of sense. And then people who've had an in vitro fertilization pregnancy are at increased risk. So that's, and there wasn't a lot of information about why they think that might be. It's just a statistic that they found. You're statistically more likely to have preeclampsia if you've gone through IVF. So signs and symptoms of preeclampsia are high blood pressure. High blood pressure is defined as 140 over 90, and it has to be after 20 weeks of pregnancy. In the past, like the diagnostic criteria for preeclampsia was 2 blood pressures greater than 140 over 90, separated by at least 6 hours, with specific lab changes. However, in the last 3 years, they have altered the diagnostic criteria. Is basically if you're symptomatic at all, you don't even necessarily have to have the high blood pressure. If you've got the things like severe swelling, spilling protein in your urine, bad headaches, if you're having 2 or 3 of those things, you need to be treated for preeclampsia. So other symptoms, so like I said, swelling, you can get like, especially in your hands, face and feet. Protein in the urine is a sign of kidney damage, and we'll talk when we go through labs like how that's tested. Headaches is a sign of lack of oxygen to the brain and an increased risk for seizure. And it's not like, oh, a dull headache. Typically a preeclampsia headache is like, this is the worst headache I have ever had in my life. It's persistent, sensitive to light. It's pretty miserable. Vision changes, which goes, again, decreased oxygenation to the optic nerve. So you can get double vision, blurry vision, or called sparkles, or like little floaters in your eyes. Upper right-sided abdominal pain, that's where your liver lives, and your liver will hurt if it is not getting enough oxygen. In severe forms of preeclampsia, you can get shortness of breath because you actually start to get swelling in your lungs or fluid in your lungs. Sorry, that's my cat being lovely. Just knocking stuff over on the counter. And then sudden weight gain. And the sudden weight gain is, I'm not going to call it swelling because you don't necessarily see it, but it is a fluid shift of fluid from inside the vessels into the third spaces. And so you won't necessarily see like puffy swelling, but you'll see the body is holding fluids. And so if you're seeing a weight gain of 2 or 3 pounds a week, that could be concerning and warrants further evaluation. So when you're counseling patients about like, in early pregnancy, we always tell people, if you're having severe cramping or nausea that won't go away, you need to let us know. So at the 20-week mark, we need to be educating our clients about what preeclampsia is and when they need to notify us as healthcare providers. And so tell them if you've got bad headaches, severe nausea, like sudden onset of nausea, vomiting, swelling that doesn't go away with like rest and feet elevations or significant increase in swelling, bad headaches, floaties in your eyes, things like that are all things that you need to teach them to be on alert for. And so, especially because, the treatment for preeclampsia, the ultimate treatment is delivery of the baby, right? Like everything that we do in the hospital to manage preeclampsia is symptom management. It's not curative. The only way to fix preeclampsia is to get the baby and the placenta out. And so sometimes the treatment is a very early delivery, which is why you need to be watching these. I think the earliest I've ever seen is a 25-weeker for very severe preeclampsia. So to diagnose preeclampsia, again, if they're symptomatic, they need to be treated as if they're preeclamptic. And in our world, that means they need to be referred to a physician so that they can get a higher level of care. So regular prenatal visits, getting eyes on your patient, watching for remember, if they're having subtle swelling, those subtle fluid shifts, they might not notice it as much if their face is just slowly getting a little more puffy and a little more puffy. or, so things like that where you're seeing them with like interval breaks, so you can notice those bigger changes that are subtly happen over time. Like somebody can be like, ooh, how are you feeling? You're looking a little puffy, increased fatigue. They're telling you like, yeah, man, I've been having headaches every day, stuff like that. You want to pay attention to those sort of things. It is vital. It is required. It is a must at every single prenatal visit that you check a blood pressure. Now, some people will say like, oh, I have white coat syndrome. It's always high at the doctor's office. Or, oh, I just got here and I'm stressed out, so it's going to be a little bit high. I want to know how high your blood pressure can get. I don't want some fake, I laid down and took a rest blood pressure, because that's not what you're doing at home. You're at home or at your job, moving around and working. And so that's what your resting blood pressure is. That means that your natural daily state of anxiety and movement is going to keep your blood pressure at that point. So when you see people, and I've seen this with some midwives, they'll get a high blood pressure and they'll be like, oh, let's just wait a few minutes and check it again. That is so inappropriate. That is such a disservice to your client. That is a very good way to miss preeclampsia early on and get them into higher levels of care. You need to take blood pressure like so seriously. And then urine testing. If you see somebody's blood pressure is going up from their baseline, or they're looking a little puffy and swollen, do a urine dipstick in the office. In the state of Alaska, it's actually law that all of the certified professional midwives have to do urine dipsticks at every single visit. I don't do that. It's a waste of resources, and it's not scientifically sound. But if you have symptoms, I sure as heck am doing it. Because if you're seeing 1+ protein, that's a sign of kidney damage. It does not have to be that significant for it to be a sign of problems. Ways to prevent preeclampsia. Yes, I will get into that here at the end. It's prevent-ish. But yes, we'll talk about it. Symptoms assessment. So when I have my clients in the office, I ask the same list of questions every single time. My patients are probably by the 9th month and their 15th visit with me fairly annoyed of me being, dizziness or headaches, nausea, vomiting, abdominal pain, swelling, all that sort of stuff. Every single visit I want to know, because if you're saying yes to this, I need to be doing a deeper dive, a further investigation. And so if you're seeing somebody who's displaying clinical signs of preeclampsia, you then need to move into diagnostic testing. Some midwives will be like, oh, it looks like you have preeclampsia, go see a doctor. It is faster for your patient if you order the labs as the midwife and get that stuff taken care of. And then you can also do your referral to get them into a different provider, but you'll have more information for that provider before the next appointment. So the lab tests that we do a complete blood count, and we look at two very specific things on the complete blood count. You'll want to look at the platelet count, because decreasing platelets is a sign that we're moving from preeclampsia into a condition called HELLP syndrome, which is much more dangerous and much more life-threatening. And then you want to also look at the red blood cell count, because also in HELLP syndrome, the red blood cells start to break down, and so they can become very anemic. And so it's important to look at those. You want to do a liver function test, which is going to give you 3 enzymes that you look at: the ALT, the AST, and the ALK-Phos. ALK-Phos is always elevated in pregnancy. Remember that. ALK-Phos, always, always, always elevated in pregnancy. So a CMP is for kidneys. So the ALT and the AST are liver enzymes. If those are elevated above baseline, you have liver damage. They need to be getting in and being seen, and especially if they're continuing to elevate over multiple lab draws. And then so you'll also want to do a CMP to look at serum creatine levels. Creatine levels are a measure of kidney function, and elevated levels will indicate that the kidneys are not filtering or excreting correctly. Uric acid levels also are indicative of kidney compromise, and so if they're not able to excrete uric acid properly, then it builds up in the system. Any level over 6 is like terrifyingly concerning. Sometimes if it looks like severe preeclampsia bordering on HELLP syndrome, you might do coagulation studies to rule out things like ITP, which is, or DIC, disseminated intermittent clotting. So DIC is a super scary complication when your blood starts clotting down in your capillary beds, and then you don't have enough clotting factors left for big spots that are bleeding, like a placental site when you have a baby, so you can have a big hemorrhage. And then serum albumin levels, which is an evaluation of both kidney and liver function, and also diet a little bit. So albumin is these little tiny protein molecules that float around in our blood, and they're there to help maintain osmotic balance between the inside of our blood cells and the outside of our blood cells. So if our liver can't make albumin because it's getting damaged, then we don't have any on the inside of our blood, and then that doesn't hold the fluids in, and then that's where we get all the swelling. So low albumin lets all the fluids in our bloodstream leak out to the outside because our body wants to dilute the outside of the bloodstream to the same levels as the inside of the bloodstream. So that's why you'll see things like the Brewer's diet that recommend like massive amounts of protein to help prevent preeclampsia. I will say that there is no great studies showing that that's an effective way to manage preeclampsia, but I don't think it can hurt anybody, so you might as well give it a whirl.
Paying attention to how much protein you eat in pregnancy typically will result in you eating more protein.
Yeah, I mean, you should be shooting for 100 grams a day when you're pregnant, which is a lot. It's hard to eat that much.
Yeah.
And then other tests that we do is ultrasounds, and the reason is to look at fetal growth, because remember, fetal growth restriction is a complication of preeclampsia. And then amniotic fluid levels, because you got a baby that's not growing, especially when you get like that asymmetrical where the head is growing and the body is not, like that's a sign of significant compromise. You need to get that baby out. And then non-stress tests where they go on the monitor and you look at, is the baby having increases in the heart rate with their movements? Because that tells us if the baby's well oxygenated and has a normal functioning nervous system. Typically, if you do an NST and it's what's called reactive, you know that baby's probably going to be good for the next 2 to 3 days. So sometimes that's used to buy time, be like, okay, this preeclampsia is getting concerning. Let's see if we can get it a couple more days. Because remember, when you're looking at early delivery, what's the risks and the benefits? Because every day you can keep that baby inside the mom is like 3 days less inside the NICU. So you want to keep that baby in as long as it's safe. So when you use tests like ultrasounds and NSTs and biophysical profiles to like help you make that decision if it's safer for the baby to be in or out, because we're working on 2 people's livelihoods here and trying to keep everybody safe, and it's a delicate balance. Okay. All right.
And we will answer questions too. So we're going to do the deep dive so that people who are here for it and are taking notes are going to be able to ram through. Please do write down your questions. Drop them in the comments though. I will be moderating. I'll make sure we go back through that none of them get missed, but we're going to let Jen keep going so we can get that nice bulk out, and then we can have some more discussion about some of the nuance.
Yeah. Okay. So complications of preeclampsia. What can happen? Why do we care? Organ damage. So preeclampsia can cause organ damage to your liver and kidneys. It can cause kidney failure. It can cause liver failure. If it goes untreated, those organs can sustain enough lack of oxygen that enough cell tissue dies that they die. I've seen one 17-year-old girl go into complete liver failure from preeclampsia that then turned into HELLP syndrome. And then HELLP syndrome is like the most severe form of preeclampsia. HELLP is an acronym. It stands for hemolysis, so the rupturing of the red blood cells, elevated,
elevated liver enzymes.
Liver enzymes, we go. And then low platelets, my goodness.
Low platelets.
My brain just totally stopped right there. Yes. So basically, the liver is getting messed up, your platelets are breaking down, and your red blood cells are ripping apart. So you've got liver damage, and if you don't have red blood cells, so you've already got these stiff blood cells, and then you're breaking down your red blood cells, so like no oxygen is getting taken anywhere at that point. So mom is deoxygenated, the baby is deoxygenated, and then the low platelet count, mom's going to bleed. So you've got significant problems. Additionally, preeclampsia can cause strokes from high blood pressure. It also puts people at significant increased risk for high blood pressure, heart disease, and stroke later in life. If you've had preeclampsia in your pregnancy, you are much likelier later in life to have issues with cardiovascular disease. Seizures are probably like the thing we most often think about. with preeclampsia, because if you've ever seen anyone in the hospital who's got preeclampsia, the beds are all padded and the lights are all off and everything, so that we can limit neurostimulation. Seizures are dangerous because, obviously like physical injury to the mom, but also during the time of the seizure, a lot of times people are not breathing or not breathing well. So if mom's holding her breath, baby's breath is also being held at the same time. So you have risk of decreased oxygenation to the baby. And then risk of placental abruption during the seizure, or just in general. High blood pressure from mom puts people at high risk for placental abruption. So there's a couple of reasons for that, or they all work together to be problematic. So the placental attachment in somebody with preeclampsia is much more shallow than it is in a normal placenta, so it's already barely attached. And remember that it's the placenta and the mom, it's almost like Velcro, so it's designed to like peel off when the baby's born, right? So if you have an injury or assault, like a seizure, that can pull away easily. But also if mom's blood pressure is really high and this is already barely hanging on, those blood vessels are just pushing and pushing and pushing against that placenta. And so it can start to peel off early before the baby's born or before mom's even in labor. And placental abruptions, before onset of labor, have like a 90% fetal death rate and a pretty high maternal mortality with them as well. Placental abruptions are one of the scariest things you can ever see. For babies, again, the complications are restricted fetal growth, preterm birth, low birth weight, and then babies that are born premature, small, or increased risk for hypoglycemia, hypothermia, and respiratory distress. So you're going to end up with a sick mom and a sick baby. So what do we do? How do we treat it? First, we monitor frequently. You distinguish between gestational hypertension and preeclampsia. Gestational hypertension, high blood pressure, no symptoms. Preeclampsia, high blood pressure or symptoms, but manifesting symptoms, liver pain, headaches, floaties, spilling protein in their urine. They've got other stuff going on besides just high blood pressure. Now, you got to monitor, though, because just high blood pressure can very easily morph into preeclampsia, so you have to be doing frequent labs. If it's early in pregnancy, oftentimes you'll see the mom's given blood pressure medications like nifedipine. While that lowers the blood pressure, it doesn't change those tiny, stiff little capillaries. So we still have risk of end organ damage, so brain, liver, kidneys, and fetal growth restriction risks. However, we've now decreased the risk of mom having a stroke, and we've decreased the risk of placental abruption a little bit, but we haven't fixed the problem. And then some doctors will order bed rest. There's not, ACOG currently doesn't recommend bed rest for anybody, but you know how some doctors and people are like, this is how I was trained, this is what I do. Bed rest, I mean, if you can do it, it's great, but most people get stir crazy, which makes them anxious, which then increases their blood pressure anyway, so bed rest isn't all that helpful. Hospitalization, a lot of times people will be hospitalized and started on medications. So for severe high blood pressure, like 160s over 110s, or higher, like a right now medication that's given to drop blood pressure is called apresoline, and that'll drop it down quickly. Again, decreasing the risk of stroke in the mom is the big one, or and then to manage the risk of seizures in the mom in the hospital, moms are put on a magnesium sulfate drip. And this is a central nervous system depressant, so it basically decreases the seizure threshold. And then in addition to that, we do like decreased stimulation. So typically they're not allowed to have their phones, computers, television, one visitor in the room, all the lights off, no children allowed at all. It needs to be kept super, super quiet in there.
Alloud's a strong word. We're not fans of allowed. This is a true neurostimulation shutdown. We're trying to reduce exterior input, so it isn't agreed upon. Let's not hurt ourselves. Typically.
And then if it is looking like the mom's gonna have to deliver prior to like 34 weeks, she'll be given steroids to help the baby's lungs mature as quick as possible. And then just, again, timing of delivery, we're going to be just balancing that. Is it, how much at risk is the mom and baby if they stay pregnant versus delivery? And so it's just a very careful watch that the doctor's ultimately the one who's going to make that decision. And then sometimes a C-section. Sometimes the stress of labor, even with an epidural, is just too significant. It's causing blood pressure spikes that are just very dangerous, or the baby's not going to tolerate contractions because it's already depleted of oxygen reserve. So it's not uncommon to see a C-section. However, remember, we're over here with preeclampsia, and if it's that severe, it's probably leading into HELP. So those are moms that are super high risk for hemorrhage. So as the midwife who's going to be getting that patient back, hopefully at some point, you got to remember that mom's going to be struggling with milk supply and energy. Those are the things that we're going to look at on that side. Yeah. And then fluid balance is another like important. So if we're at the birth center and we're laboring along, and all of a sudden this mom's like, I don't feel good. Something doesn't feel right. Her blood pressure is through the roof. Don't start an IV bolus on her, because remember, she's already going to be retaining fluids. Her kidneys are not working to process them out. It's very easy to go from that to swelling to start in the lungs, pulmonary edema, which is really scary and you can die from. I've seen moms intubated in the ICU giving birth because of pulmonary edema. So you want to be careful with that. And then, so postpartum care for us is going to be like persistent and frequent assessment, because postpartum preeclampsia can happen even after preeclampsia has happened. They can get worse again. And so you just want to be monitoring them for nausea, vomiting, headaches, stomach pain, stuff like that, because they're still at risk for seizures. And that's scary. And sorry, I talk so fast, you guys. I apologize.
Okay. Yeah, it's note-taking time.
Symptoms of postpartum preeclampsia: high blood pressure, swelling, sudden weight gain, severe headaches, vision changes, upper right-sided abdominal pain, shortness of breath, nausea and vomiting. We don't understand why postpartum preeclampsia exists. It's believed to be related in changes to blood regulation and the sudden reduction of pregnancy hormones. Women who had preeclampsia in their pregnancy are at higher risk of developing postpartum preeclampsia. Postpartum preeclampsia is defined as preeclampsia developing in the first 6 weeks after delivery. So you have to, I mean, that's why we need to be watching our moms very carefully those first 6 weeks, not just have a baby and I'll see you in 6 weeks. We need to be there, making sure that everybody's okay during those first 6 weeks. Diagnosis is going to be pretty much exactly the same, and treatment is also going to be the same. It is going to be in the hospital. If you have a postpartum mom with high blood pressure, you need to get labs and you need to send her in. Like, we don't mess around with this. You don't want these moms stroking out. You don't want them throwing blood clots, having seizures at home. If you are concerned at all that this might be postpartum preeclampsia, it is better to be wrong and refer than miss it and have significantly bad complications. Yes. So.
Mm.
Yeah.
Anything else?
That last comment there, I would guess that you had like a postpartum preeclampsia that caused like a nasty inflammation, and like the healing of your capillary beds took 7 months before your blood pressure came back down to normal. And I would bet if you did a urine test today, you probably still spill protein out of your urine. That's something I can talk about. So let's say we had a patient who had preeclampsia in her last pregnancy. And that's good to know, right? Remember, if you've had it before, you're at increased risk. So when you do your initial labs, you need to do kidney functions, liver functions, and do a 24-hour urine protein collection, because you need to know what her baseline is, because she's coming into pregnancy with damage already. Like, that liver already took damage from the first one, that kidneys already took damage from the first time. And so you want to know where she's starting so that I can see elevation. Because if my kidneys are already spilling 200 milligrams of protein in a day, and then you get the labs back, you're like, oh my God, it's 400. That's huge. That's awful. It's severe preeclampsia. No, I mean, it's up there. It bears watching, but it's not as scary, because like I started out dumping some proteins. 300 milligrams of protein over 24 hours is kind of the cutoff of normal protein loss versus excessive related to kidney damage protein loss. And then somebody had asked earlier, can you prevent preeclampsia? And I said, kinda, not really though. it is recommended that if you have a patient who has had preeclampsia in the past, that you have them take 81 milligrams of aspirin every day. Again, we can't fix the genetics. We can't fix the placental insertion, but what we can do is the aspirin makes it so that the blood is a little bit thinner and a little bit slipperier, which lets the oxygen and nutrients exchange a little bit easier at those stiffened capillary beds. And so it can help prevent some of the complications of preeclampsia, but no, we can't really truly fully prevent preeclampsia.
Well, and let's also take a minute too, because we don't know. There are there could be many reasons. And like Jen said, when we see hypertension showing up, that could all of a sudden cascade into a presentation of preeclampsia, or it could stay this way. We've seen that between different partners. Somebody who's had preeclampsia in one pregnancy may not have it if they have a different partner. And so when we say things like, can we prevent preeclampsia, we have to be really careful that we don't fall into this maniacal, I can make it not happen energy. And because some clients really want to, like, I'll do everything and I will prevent it. And I want to say,
I feel like failures.
Like, take care of yourself, right? Like, if you really want to prevent preeclampsia, eat regular amounts of food, keep your blood sugar stable, keep walking at least half hour a day, like things that are great for cardiovascular health and perfusion, good amounts of electrolytes, hydration, and protein intake. These are all helpful, but will they prevent preeclampsia? Absolutely not.
Yeah.
Absolutely not. But they may help your body be more supported. And if it was going to be a problem, had you not done that, now you don't have it, but we can't say it prevented it. It was your attention to the nourishment that might. But the thing is again, it can happen for so many reasons. At implantation, something genetic, something between partners genetic, and we cannot say yet exactly what it is. So we do not like the slippery slope of you individual can prevent preeclampsia.
So instead what we say is, like, with science, we know that if you take 81 milligrams of aspirin every day and you've had a history of preeclampsia, you are less likely to be diagnosed with it in a future pregnancy.
Yeah.
We know that. Differences between postpartum pre-E and hypertension. So postpartum preeclampsia, you're going to have those other symptoms. So you're going to have spilling of protein, headaches, visual disturbances, swelling. Hypertension is just elevated blood pressure without symptoms. Typically, if you have blood pressure issues that last longer than 6 weeks postpartum, you are typically referred to as chronic hypertensive at that point. And remember, chronic doesn't mean you're always going to have it, but it is just a difference in, like, acute, something short, versus chronic and requiring, like, different types of treatment. So postpartum preeclampsia, sometimes you'll see people get put on blood pressure meds. A lot of times they just need 24 hours on magnesium sulfate and their blood pressure drops down. But mag's not a blood pressure medicine. I don't know if we fully understand why the 24 hours in the hospital on mag seems to settle out the body and kind of reset the blood pressure system, but it does work pretty good.
Severe magnesium deficiency on a ground soil level on our food system might be part of it, but we don't know.
Yeah. But chronic hypertension or hypertension that's not getting better after 6 weeks is definitely is considered not an obstetrical problem at that point. It is something where they would generally be referred to see their primary care provider and be treated with, like, breastfeeding safe blood pressure medications like labetalol, nifedipine, things like that.
Okay, Jen, we have a question further up here. I scrolled back up to some of them, and I'm curious to know if there's any link between ICP and preeclampsia.
There is not that I am aware of. Intrahepatic cholestasis of pregnancy is like the cholestasis means things are not moving well out of the liver. That has more to do with the products of the liver, the bile acids, the things that we use to break down fats, and basically they're not moving from the liver into the gallbladder, into the intestines, and backing up like into the bloodstream, and then causing things like jaundice and itchiness, like severe itchiness of your hands and feet, especially at night. And IHCP is super high risk of fetal death, like 20% if you're not delivered at 37, 38 weeks. But that doesn't have anything to do with like the elevated liver enzymes that you see in preeclampsia. It has to do with decreased oxygenation to the liver, not the moving of the liver products from the liver into the intestines. Does that make sense?
Totally. Because you're having a cardiovascular sequela from the preeclampsia and the stiffening
Right.
in those capillaries.
What do you mean if that is actually working? Can you
Yeah, is that about the MAG, Marie? Marie is a Radical Births. Everybody go follow Radical_births. She is a newly certified professional midwife and NARM preceptor, and she has quite a story. She will be coming on to talk with us about and all sorts of other stuff to share. She has attended birth in so many places. And I'm so excited that she's doing what she's doing. She is going to be changing the world specifically for bodies of culture and midwives of culture. And I'm really excited. We love supporting you, so whatever we can do. And yes, for the mag sulfate, going back to your question specifically, yes,
Okay.
she is a midwife. She is a midwife, certified professional. I know she just got her little letters, and I wanted to give her a shout out, Marie. And so, yeah, for the mag sulfate, I wonder what the research shows if that is actually working. And so by working, you mean if the mag itself is what is dropping the blood pressure?
I mean,
Go ahead, Jen. What are your thoughts?
what was
Go
that?
ahead. I said, go ahead. What are your
Oh,
thoughts?
okay. There was like a
Go
feedback loop. I thought somebody else was talking. I mean, it's a central nervous system depressant, and it can be an overall like smooth muscle relaxant. So it could, I mean, in theory, yeah, it's a smooth muscle relaxant, and our arteries are made of have little tiny smooth muscles in them, so it could be dropping blood pressure in that way. We also know that, I mean, we used to use MAG to, we thought it would stop preterm delivery, but it doesn't, because if it did, then we wouldn't have preterm babies. So it does sometimes slow things down, but if you're in labor, you're in labor and you can't stop it. But through using it to try to stop preterm labor, what we did discover is that babies who are exposed to magnesium sulfate have a much decreased risk of developing cerebral palsy. So it's called neuroprotective mag. So moms who are in preterm labor are often given magnesium to try to prevent cerebral palsy in the babies. Again, it's a lot of just, I think, decreasing stimulation to the brain, slowing the brain down a little bit, makes the baby's brains a little bit more able to handle some of that oxygen deprivation that's associated with cerebral palsy. So, yeah, let me see if I can find any scholarly articles about magnesium, sulfate, and postpartum preeclampsia.
All right, more questions. I think we've answered all the ones so far. I'd love some more. You can see my forehead as I scroll. I'm so happy to see everyone here. Another shout out. Go sign up for our email newsletter list. We sent out something yesterday about what's happening today, and that newsletter has a link to fill out if you're interested in going to Hawaii for CEUs or a retreat. We are taking interest. And January through March 2025 is looking really popular. So if you're interested, it's just a Google form. You're not buying anything. We're just getting info from people and what they want to do. But yeah, go sign up for the email. What do you got, Jen?
Oh, I was just looking at a comparative between a 12-hour mag infusion versus 24 and seeing what they thought. Yeah, 12-hour infusion for mild to moderate preeclampsia is as effective as 24 hours, it looks like, according to this study that was published in, it was 2014, so it's a little bit old, but I mean, mag makes you feel like crap. That's the other thing. As a midwife, I mean, our job, once we transfer our patients into higher levels of care, is to, provide anticipatory guidance or, give them the good old heads up about what's going to go on. Mag makes you feel awful. You're hot, you're sweaty, you're nauseous, you're tired. It's not a fun drug to be on at all. Yeah. And they're not allowed to get up, so they're going to have a catheter in their bladder. Again, we're using the total amount of urine made as a measure of kidney function. So normal kidneys put out at least 30 milliliters of urine every hour. If you see somebody's kidneys are not making that much, then that's a worrisome sign that they're in kidney failure. So yeah, so and then because they
So
can't get up,
have your clients pee in a quarter cup every hour, and we'll see what happens, right?
no,
No.
yeah.
Send them in. Don't do that at home.
Just put like having the flu, vaginically on fire. Oh,
Oh,
oh man, I'm so glad I never had preeclampsia. That sounds awful. I'm like, can
that
I get an
does.
epidural for that part? I don't need it for the contraction.
Yeah. And yeah. So with preeclampsia, if you do have a client that's coming into care and you are a doula, you are a midwife, you are working with a community member who is employing your services to attend them, knowing that they have a history of preeclampsia does matter, because then as you walk side by side with them in any capacity, you as the provider, even though of course doulas aren't giving medical advice,
But you
right?
get a
Like,
heads up what to
but you
expect.
have a heads up for what really could be happening, so that this client may get a community birth. This client may also need to transfer before her labor even starts, or their labor even starts. That their blood pressure and them staying active but watching their blood pressure, because like Jen said earlier, something that seems to float around in the community birth space is this relaxation before blood pressure. And yes, we want our clients to be at a nice
Right.
homeostatic baseline. We want them to be calm and in their bodies. So we typically don't do that we don't want to assault their
I'm not
body
gonna
right
run
when they come
upstairs
in.
and I take their blood pressure, but I'm also not gonna falsely have them rest for 10 minutes before I do it either, Sit down, do my
Exactly.
stat, take a blood pressure. Yeah.
Because if we start to do things like that, then we're getting a little too involved in what just happened? Why are we getting involved? The numbers really do matter. And so with clients, like Jen said, you have a client whose blood pressure is 146 over 92. Okay. And she's 38 weeks. Okay. And you're like, well, darling, I'm going to need another blood pressure in about 6 hours. Okay. I'm going to need another blood pressure, whatever you're doing. And in fact, I kind of need it to be in that middle of that point, because I don't need falsified. And in fact, between now and then, I don't want you go rest if you're going to go have food, but don't try to keep it low so that you don't show. Like, that is not what we ever want to do. We want our clients to be just rolling, doing their thing. And a lot of my clients, I'll say, hey, if you're going to be going to the store later, some of the stores have those blood pressure cuffs. You can do it there. This doesn't have to be a big, yeah, got to come back to the office. It's hey, go get it and shoot me a picture of it, right? So I can see that. Because then it is good to, and this is that anticipatory guidance we give in office. Your blood pressure was high, but we're going to give it 6 hours. We're going to see what it says. If we have another high blood pressure, this is anticipatory guidance time. We are going to be talking about, hey, we need to talk to somebody higher up. We need to get our labs run. We need to start looking at what could potentially be going on. And so already we have our labs drawn. We already sent her home with her little urine bucket probably. We're going to ask, or we're going to give her a little cuff to take home, or we're going to get her blood pressure in 6 hours. But we give her the heads up that there will be, this is the step of what we're going to do. If this, then this. If this, then this.
Yep. The 6 hour gap is to make sure you didn't just get a random elevated, one-time elevated one, like from anxiety or, something like that. The 6 hours should give them time to where you feel like this is how they're resting blood pressure. This is just a normal blood pressure. The one we got wasn't a fluke. It wasn't just related to them being upset or anxious or in pain or nervous or anything like that. So. And then the previous question about thalassemia and pre-E. So any inherited anemia, so like sickle cell and thalassemias, they do put you at increased risk for preeclampsia. And people with thalassemias typically have lower blood pressure, like low normal to low blood pressure. So seeing increases in their blood pressure, if you have a patient who has thalassemia or sickle cell and you see their blood pressure start to increase, like above their baseline, even if it's not high blood pressure, but it's above their baseline, you need to do labs. You need to check on them.
Mm-hmm. Absolutely. And Jen, does that have anything is that just because there's variable oxygen carrying capacity already in expressions of sickle cell or thalassemia that you'd want to
Basically
really
it's like,
keep an eye?
I mean, you're
Okay.
already going to have reduced placental function just because of the thalassemia.
Mm-hmm.
And it's,
Not fun.
so yeah, that's just how it is. So yeah, anybody who doesn't have normal shaped blood cells, you got to watch carefully. So, and then people with sickle cell are already at high risk for clots and pain. And sickle cell patients should probably not be out of hospital birth candidates. There's a lot of risks there.
But we're going to let it roll right now because it's not
Yeah.
like we have a lot of OBs signing up and hospitals popping up everywhere ready.
It's true.
So we're
Yep.
going to be
And
but we're going to
everybody
be
has their
aware of
own
it.
acceptable level of risk
Yep.
for the patient and the
We're gonna
midwife,
be
and
aware.
you get to
That would
collaborate
be
with people who vibe with your acceptable level of risk.
That would be a fantastic topic, though, for a conference or a CEU right there, is
Acceptable
like
level of risk.
community guidelines, just
Yeah.
like community guideline guideposts for
Yeah.
sickle cell clinical. If you guys are interested in that, let us know, because that would be really fun. That'd be fun to bring something in on. So yay, awesome. Okay, more questions. Postpartum preeclampsia is Marie here, Radical Birth, shared something on her page yesterday because she went to a conference specifically. And if you would please, Marie, put it in there, the name of the organization that you saw it. But I think it said that post-pregnancy related deaths in the first 6 weeks are at 21%. And postpartum preeclampsia specifically is something I don't think a lot of midwives get a lot of training in. And it's actually how it's the extension of really rigorous clinical training to keep assessing for these vital signs after baby's out. We do blood pressure, but upper right quadrant pain, right after birth, sometimes people will say, oh, I hurt, and somebody will say, oh, you pulled a muscle, push it. Yeah. And it's like, that is not a pulled muscle.
No.
Like if you are vomiting, if you have a headache that's not going away. Jen, I would love for you to also talk about clonus and could you talk about edema?
So
And,
when you're like, so if you have a patient, like I'm pretty sure you say it's preeclampsia. One of the ways that you can assess their like kind of their seizure threshold, like how excitable is their nervous system right now, like how on edge is their nervous system, is you can check their reflexes. If you tap their knees or you do the arm one, if those reflexes are like jumping off the bed at you, like that's a sign that their nervous system is highly excitable and that they're at increased risk for seizures. And another one you can do is have them lay flat on the bed and you pick up their calf here and their foot here, and you kind of get their foot nice and loose, and then when they're not expecting it, you push their toes back towards their knee. And if their foot involuntarily beats back like that, that is a high level of nervous system excitability and increased risk for seizure activity. So that's something that you can do as part of your assessment when you're looking at signs and symptoms of preeclampsia. And then edema. Again, edema alone is not indicative of preeclampsia. It's one of the many things. So simply having somebody go swelling alone is not a reason to do labs. They need to have it in combination with other things. I hope I lost Jess. But we can gauge swelling and be able to view how much it's changing from visit to visit. So pitting edema is when you like push on like usually their shin. Push really hard for like 3 seconds and then let go. And if it's leaving a small dent, that's like +1. And if it's there for like, 10, 15 seconds before it refills, like it's there, but it's not crazy. Push it in again. Like if it's deeper, it's basically a depth. So it's like a little shallow dent, like, half a centimeter would be like +2. And then like more than that would be +3, which is concerning. That's a lot of third space fluid. That's a lot of weight in water that's hanging out in their legs. So that is edema assessment. And again, that's just that's looking at kidney function if they're not moving the fluids out of their system, and they're backing up in the system causing swelling, and liver function that they're not making enough albumin to hold those fluids inside. Jeff, what are you doing? You're throwing your phone around. Get crazy.
I know, I plugged it in and it lost its mind. It was like, oh, you're charging me? I'm going to switch the camera, shut off everything. Oh, okay. Which is good, though, because we are at about 2 minutes to the hour, and I know, Jen, you got to hop on telemeds, so we want to respect everyone's time. So, guys, this was Pre-Eclampsia. This week, we're going to have another live next week, 1 p.m. Pacific Standard Time here. I will announce the topic. We'll put an event live on our page on the Facebook, the Facebooks, and we'll add one into Midwives Anonymous again, the group there. If you have a group you want us to add an event into, doulas, anything like that, let us know. We love to make them there so everybody's audience can see us.
Comment with suggestions for future topics. Questions about this topic, constructive feedback. I know I talk too fast, but I'll work on it.
Yeah, yeah, totally. And and also we have up on our site right now, we have an immediate download, neonatal hypoglycemia. The course, it's an ebook course, and it has everything from the criteria, diagnostic criteria, the calculations for using glucose gel in the community birth setting, especially if you already have a baby that is low blood sugar and you are in a rural setting and you have more than an hour or 3 to get a baby where it needs to go. Everybody should be carrying gels. So we did create a downloadable book. It's 26 books. And it's on the website. So check it out. Sign up for the email. Go to Hawaii with us. Because we want to go to Hawaii, so the more the people that go, we all get to go. So this is great.
That's right.
Otherwise,
all right, you guys. Next week, I'm going to sign off so I go back to work.
All right. Mwah. Bye, everybody. See you next week, every Wednesday.